few years ago, I got a call. My good friend and neighborhood retailer for over a decade had been in an accident. Mike had a passion for the outdoors, animals, and working the land. He lived on several acres, and one day his wife looked out the kitchen window and saw smoke coming from far off on the property. It turns out Mike had passed out on his lawnmower and slammed into a tree. Once at the hospital, he saw several doctors, went through multiple tests and scans. Finally, he had a diagnosis: glioblastoma, which is an aggressive brain tumor with a median survival of only 14 months. At the time, I had recently started working with my former mentor at Case Western Reserve University to commercialize a technology that would allow clinicians to clearly see tumors. This technology can help clinicians to see brain, breast, prostate, lung, gynecological cancers, and melanoma. However, we are focused on brain tumors due to the invasive nature and severity of the disease, as well as the short survival time. The standard treatment for patients with brain tumors is to undergo surgery to remove the bulk of the tumor and then go through multiple rounds of chemotherapy and radiation. In talking with clinicians, we were learning that they face three main challenges in treating tumors. First, they could not actually see the tumors and instead rely on nonspecific images such as MRI or PET to see what is going on inside the patient. While beneficial, these images can often be difficult to interpret because tumor tissue, necrotic or dead tissue, and tissue inflammation can look the same. Second, surgeons were relying on their experience, their expertise, and the naked eye to remove as much tumor as possible while leaving normal tissue intact. These clinicians know that removing as much tumor as possible increases their patient's survival. But even the best surgeons still leave behind tumor cells, which is the cause for 90% of tumors that do come back. Third, there is a serious lack of therapeutics available for brain tumor patients post-surgery, in that only 5 drugs have been approved by the FDA for treatment of brain tumors in the past 3 decades. Only one agent designed to help visualize brain tumors was still in clinical trials with the FDA and was not readily available to help Mike. My mentor at Case, Dr. Suzanne Brady-Kalnay, is passionate about improving patient care. She has studied a group of molecules which play a pivotal role in cancer cell progression, invasion, and recurrence for over 30 years. She found that one particular molecule called PTP-mu is cut on the surface of tumor cells. Once PTP-mu is cut, a unique shape is present that is only found in the tumor microenvironment, not normal cells. She realized this unique shape could serve as a target to seek and destroy cancer cells. In the years following, she developed a number of agents that precisely recognize this unique tumor target and paired the agent with different tags that function as beacons for tumor imaging. For example, radiologists typically see a black and white MRI image like this, with what looks to be a lesion in the upper corner. But is it a tumor? Is it inflamed tissue? When our agents are paired with contrast-generating metals, such as gadolinium, you can achieve tumor specificity demonstrated in green, improving sensitivity of an MRI image. Surgeons need better tools to see tumors in the operating room. Glioblastoma is not only aggressive, but highly invasive, extending finger-like projections of tumor cells into normal brain tissue. During a craniotomy, neurosurgeons need tools to clearly see the edges or margins of these tumors to precisely determine where the tumor ends and normal tissue begins. By attaching a fluorescent dye to our tumor-specific agents, they can then be used with a standard surgical microscope filter to clearly see the tumors in the operating room in real time. Dr. Brady-Kalnay's imaging agents specifically recognize the primary tumor mass, clearly define the tumor margins, and target the finger-like projections of cells that have migrated away from the primary tumor. What is really exciting about making invisible tumor cells visible with fluorescent dyes is that these tools can not only improve the surgeon's ability to distinguish tumor from normal tissue during surgery, allowing them to safely resect as much tumor tissue as possible, improving patient survival, but they can also function as a therapeutic after the surgery. I mentioned earlier that it is these cells, the invading cells, that are invisible to the surgeon, account for 90% recurrence of brain tumors. Clinicians need effective treatments for the tumor cells left behind. Research has shown that some fluorescent dyes can also be photosensitizers. What this means is that these dyes, when exposed to a specific wavelength of light, can selectively damage the tumor cells. The light is absorbed by the fluorescent dye, and a chemical reaction creates reactive oxygen species, which damages the cells. Heat is also generated in this process, further damaging the cells. Once the cancer cell death has been activated, an immune response is stimulated in the body. The body's own immune system then targets the tumor cells. In order to get these technologies into the hospital, Dr. Brady-Kalnay founded NeoIndicate, an Ohio-based company focused on advancing tools for improving tumor detection, imaging, and treatment. The lead fluorescent imaging agent has been independently manufactured and validated to specifically target tumor cells in models. Dr. Brady-Kalnay has partnered with world-renowned neurosurgeon Dr. Sloan at the University Hospitals of Cleveland. He is eager to get these imaging agents into the operating room and is poised to run the first phase 1 clinical trial in 2022. I talked with Mike not long before he passed. We didn't talk about cancer, we just talked as friends, as I had for so many years sitting in his shop. I'm grateful for that moment, and every day in our work, I'm thinking about Mike and people like him, and how this technology can change people's lives.